we thought we'd go ahead and get started with our presentation tonight because this is really an interesting time in healthcare, as we all know, all of us who work in it. And it's really a privilege to have someone like Rich Umbdenstock with us tonight to share his wisdom and of many years in healthcare and many years in Washington, D.C. with the American Hospital Association. My name is Jim Hall, and I'm the Director of Government and Community Relations at Kadlec, and I'm involved in legislative advocacy here with Kadlec. And it's really neat for me. Part of my job is to work with members of our Kadlec board who are involved in advocacy, and it's important enough for Kadlec to have a designated committee of its board participate in legislative work. And I get the honor of escorting and going with folks back to Washington, D.C. to attend the American Hospital Association meeting every year. And I think it really is important, obviously magnified by what a major issue healthcare is in our world today. So I want to acknowledge those folks who are on our team who participate and thank Rand and the executive team for making it such a priority, and the board for making advocacy for healthcare and the people that we serve such a major issue, and major issue with Kadlec in particular. So thank you for being here tonight. Thank you for all the folks who have traveled so far to join us. It really is neat to see. And I want to make a couple of housekeeping items. We have with us, first of all, you have a wonderful booklet put together by Antoinette and Vanessa and everyone putting on the event. There is a little addition that we want to put in there that has an evaluation. This is, I think, the 5th year that we have had this presentation here in the Tri-Cities, where we brought healthcare speakers from across the country to share their expertise with us. And so we'd ask that before you leave, you take a moment to participate with this. And it also includes, we have our friends Nick from Charter Cable here in the Tri-Cities is videotaping this. So all of you, if you'd like a DVD copy of tonight that you can share with either your board or your legislative team or your advocacy team or folks within your community, feel free. We'd be happy to send as many copies as you would like home with you, or we'll mail those, obviously, once Nick gets those put together. But also, for those of you who are in the Tri-Cities, I'm planning to have this broadcast here on our cable access channel. What channel are you on now, Nick? 190. 190. We used to be on channel 3, a favorable cable position, but we got moved to channel 190. But that's okay. We're glad that Nick and Charter are here to help us. I would like to introduce to you now the chairman and the president and CEO of Kadlec Regional Medical Center. Actually, since the affiliation, your official title now, Rand, is the CEO of Kadlec Regional Medical Center. He can explain all that to you. But Rand Wortman is the CEO of Kadlec and has really set a wonderful vision for this organization here in the Tri-Cities, and we're thrilled to have him here tonight to welcome our guest speaker. Rand?
Thank you, Jim. A couple of housekeeping items. There's 3 other members of my team here. Jeff Clark, who does our, what do you do, Jeff? Strategic planning and rural relationships. That's not the right title, but that's what he does. Ken Lester is back there somewhere. Ken runs Kadlec Clinic. Did he leave and go to work? Okay. And Bill Wingo is here somewhere. Bill is in-house counsel. Stand up, Bill. There he is. Is Dave Rose back there? I didn't see Dave come in. Stand up, Dave. Dave's our Vice President for Information Technology. He makes all the pieces work. So, we also have several board members here. Sam Volpentest chairs our advocacy committee. Sam, you want to stand up for a second? Susan Creed's back here somewhere. Susan's the chairman of our board. Now, you're not standing up. I know you're short, but stand up. That's Susan. Susan served 12 years on our board, came off for, 3 or 4 years, and she came back for 12 more. She's a glutton for punishment, but she's doing a great job. Mark Galen is one of our board members. Ted Samsel is a retired orthopedic surgeon and board member. Jerry Roach, y'all don't speed because he's a judge over in Pasco. And Larry Yecka. Dr. Yecka was the public health physician here until he retired, and he's still the public health physician for where, Larry? Walla Walla and Columbia counties. So then I want to make sure I don't forget to thank Antoinette and her team for putting the event together tonight. Have to use notes because Rich's information is longer than my old memory. Rich joined, well, for those of you who may not know Eastern Washington, some of the history, Rich was the, I don't know what his title was, but he was a senior executive for Providence in Eastern Washington, and he was responsible, I assume it was Sacred Heart, Holy Family, Chewelah, Colville, and the management contract in Colfax, is that right?
And Missoula.
Oh, and Missoula.
Polson and Great Falls.
Polson and Great Falls, okay. So anyway, they eventually merged in with Providence over on the west side, and that's the organization we joined, which is the two together. But anyway, Rich spent, did you say 27 years? In Spokane before he became, and he was chairman of the board of the AHA, and then became the president and CEO of AHA. He went to AHA in January of '07. He has experience in hospital administration, health system governance, management and integration, association governance and management, HMO governance, consulting, and he's written several books and articles on healthcare. He has a BA in politics from Fairfield University in Connecticut, master's in healthcare administration from Stony Brook in New York. He's a fellow of the American College of Healthcare Executives. He currently is the vice chair of the National Quality Forum. He serves on the board of Enroll America, co-chairs the CAQH Provider Council, and serves on the National Priorities Partnership. He'll have to explain what some of that is. Rich is a busy guy. We talked to him 2 years ago about coming out and talking to us, and we just couldn't make calendars work. And about 12 to 18 months ago, we booked him a year in advance, and thankfully he's able to make it this time. His real claim to fame is he has a daughter who's an anesthesiologist, and she works at Kadlec. So with that, I'll give you Rich Umbdenstock.
Thank you for the opportunity. What I want to do tonight is just a couple of quick things. I'll start with just a little bit about the American Hospital Association, for those who might not know. And then I like to look back on what we did, what we're doing, and where we're going, and kind of organize things in that way so that maybe it's a little easier to hold on to some of it. Some of it will be Washington, D.C. oriented. Some of it will be field and delivery system oriented. And hopefully some of it will help you make sense out of where we think things are going or should go in the future. Happy to take your questions, listen to your comments any point. Don't want you to have to sit there and listen to a lecture at 6:45 in the evening. So, the American Hospital Association, 5,000 hospitals, about 43,000 or so individual members. We have every imaginable size, shape, location, type, ownership, whatever model you want in hospitals. If you're licensed as a long-term acute care hospital, a short-term acute, general medical surgical, small and rural, critical access, academic teaching, long-term, acute rehab, licensed as a hospital, you're eligible for membership. And generally about 90% of the hospitals in the country are AHA members. The 43,000 are maybe some of you on the staffs of hospitals. Typically in areas that we have affiliated societies in HR, volunteer directors, risk management, environmental services, plant and engineering, a variety of the functional areas where people join for both networking and professional development. We're an advocacy organization. We advocate at the national level, both in the public sector with the Hill and the administration, all the agencies, but also in the private sector. National level entities like the Joint Commission, the National Quality Forum, which was mentioned, National Fire Protection Association, and other groups that affect your organizations directly and where the regulations that they're promulgating are of importance to you. Obviously, we're an education, information, knowledge exchange type of organization, like any trade association. But we're not like any trade association in two ways. First, our mission, first of all, our vision statement actually doesn't mention our member. It says that we envision a society of healthy communities where each individual reaches their highest potential for health. We're about our customer's customer. Because hospitals don't exist to serve themselves. They exist to serve patients and communities. So everything we do, we put in the context of patients and communities. Anything else looks self-serving to the hospital itself. So we're different in that sense. We're also different in that very few national trade associations can say that they have a member in each congressional district, which is the first, second, or third largest employer in that district. So as my former boss, when I was assistant to the president of the AHA back in the 70s, used to tell me, they return our phone calls. If we're speaking on your behalf, first of all, if you're in town, they want to see you. They want to hear from you. You are key community leaders. You're voters. You typically represent more than just the hospital. Maybe if you're on the board, other employers in town and so on. But the hospital itself is key to economic stability, economic development. So they want to hear from you. Second best, they hear from us on your behalf. And they listen. We have great relations on both sides of the aisle. As I like to say, you know, some of you may not think that D.C. gets a lot done these days. I'll prove you wrong. They do a lot of bad things. But as I like to say, we do the very best with the ones you send us. Okay? So if things aren't going quite so well for you, you know, send us someone different. We'll work with them too. Okay. So what did we do? We formulated a plan called Health for Life, Better Health, Better Healthcare with 5 components starting in 2006, knowing that the 2008 election would be an open election. Vice President Cheney was not going to run. So you'd have a new Republican slate and you'd have a new Democratic slate. And we were headed into the Great Recession of 2007 or so origins. We knew the economy was struggling, and we knew that healthcare costs would be a major topic. So we needed to be ready to say, what are we for? What changes would we promote? They were embodied in Health for Life, which is still available on our website. It had 5 areas, and when we finally got to the passage of the Affordable Care Act, we put it up against those 5 areas to say, is this something we can support? I won't take you through the history of that. If you have questions as to how some parts of the bill came together, I'd be happy to talk about that in the Q&A. But we basically said, let's start with our 5 platforms and let's start with coverage. So I like to say that when somebody says, why did the American Hospital Association support the Affordable Care Act? I say there were only 32 million reasons. Because that was the number of Americans that we hoped to get into health care coverage through the features of this bill. Now we know it didn't happen, but frankly, as I'll talk about in just a second, some significant progress has been made there. But we've been advocating for universal coverage, therefore universal access, for decades, and this was our best shot at taking a major step in that direction. Now, after the Affordable Care Act, if it had been fully rolled out the way it was designed, you still would have 25 million or so Americans without health care coverage. So we were basically lopping off about 60% of that problem, but we were still left with I shouldn't say Americans, that's not correct. There would be 25 million people living in this country, some legally, some not legally, that would not have coverage, all of whom could show up at any time at any hospital. So we didn't get into the immigration issue. Frankly, they took illegal immigrants off the table very early in the debate. So there was a lot in there around coverage. A lot we didn't like. We didn't propose 50% of this coverage being done through an expansion of Medicaid for a lot of reasons. But be it as it is, that's the way it came out. Wellness. We know that there is very little for a provider organization by way of a business model in wellness. Now, certainly we want to keep our own employee health costs low, so wellness in that sense makes sense. But on the other hand, for the general population, and here's your first schizophrenic moment, as you know well, for the general population, if we don't treat you, we don't get paid. So we're incented to treat, and some would say a lot, fee for service. So this was a very important plank for us because, frankly, again, in the advocacy world, everybody knows what the incentives are. And you can't walk in there and say, well, geez, I'm just following the incentives, you know. And they're saying, well, did this person need this treatment? Did you do it twice because you didn't get it right the first time and get paid again? You know, a lot of political vulnerabilities there, much less what's right for the patient. So the bill starts to take some significant steps in that direction. Coverage for wellness visits under Medicare, money for public health that hadn't been there before, a variety of things that start to say, you know, we've got to move down this track. So that was a plus. Affordability and cost, again, back to the main driver of the debate at the time, rising healthcare costs. But you know, most would agree, as they say in All the President's Men, follow the money. You know, what are the incentives? We didn't know how to change the payment system. It wasn't even proposed that we wholesale change out fee-for-service for something else. You might remember that in the mid-90s, we had this experimentation with so-called managed care and HMOs. Really wasn't the fundamental HMO system or the true managed care system. A lot of political fallout. Congress was not willing to say HMO. They were not willing to say a capitation system. They were not willing to lock in voters to a closed system. So they came up with a variety of things to try on a pilot or trial or demonstration basis. Bundled payments, well, we kind of have that in diagnosis-related groups. You get a fixed amount of money for the inpatient stay, but you don't bundle in the physician, you don't bundle in the post-acute, a lot of other aspects to that episode. Accountable care organizations, HMO light. As much as they could do like an HMO without ever saying HMO, you know, to the voters. A variety of other things that we're trying, pay for performance and so on, which leads us to the connection to quality. How do we get to value-based purchasing or pay for performance or whatever you want to call it, where you start to link payments to better outcomes or, said negatively, takeaways, penalties for not performing. So we had publicly agreed upon clinical measures being publicly reported since about 2002. The bill pushed farther down that track. Then the last thing really wasn't in the Affordable Care Act. It was in the stimulus bill, and that's the subsidies for health information technology and electronic health records. We consider that part of reform, passed about a year earlier, but clearly that was part of the equation, moving the information that's necessary to the point of clinical decision making. And that's what the whole purpose of trying to go electronic was. So we're still struggling with a lot of these, whether it's Medicaid expansion or meaningful use, functionality, interoperability of records, trying to get more of an orientation towards health. We know that we've slowed the rate of healthcare expenditures on a per capita basis. We still have too many capitas coming into Medicare, so the federal government still has a problem. More baby boomers getting to age 65 every day, so on a volume basis they've got a problem. But the bill is working in some senses. Certainly some would argue, let me start with cost, some would argue that this slowing of the rate of increase has something to do with the changes that were both underway before, because the downward trend started before the ACA, and the specter of many of these aspects. We're all getting the message that if this stuff sticks, it's going to change things long term. And so people are changing the way in which they organize, deliver, pay for care. So the best guess from researchers is that about 70% of the slowdown in the rate of cost increases is due to the recession, and some 30% or some major portion of that 30% due to fundamental changes in healthcare organization and delivery. The other is that CMS just announced that about 7.8 million people got coverage in the state exchanges, about 8 million through Medicaid, traditional and expanded, and about 3 million under 26 are now on their parents' policies. So you've got plus or minus about, let's say, 20 million Americans in the first year. Now, several of those, again, in the exchanges have to continue to pay their portion of the premium, and there's a lot to be sorted out over time. But for a website that didn't work, and that a lot of people said, this would all be too unaffordable and so on. 20 million is not a bad number, you'd have to say, out of the original 32. But we don't know where it's going to settle in, so we don't want to claim victory, unless you're the president, in which case you've declared victory, and this is working. The other thing is that CMS informed the field recently that the number of offerings on the state exchanges by the private insurance plans will increase by 25% in year 2 over year 1. That would seem to indicate that the insurance industry is warming up to this and figuring out how to work in this space. So early indications, positive, lot yet to be settled. Okay, let's move along. This is now the beginning of the good news of what are we doing. We are doing some terrific things to redefine, reorganize, change fundamentally who we are and how we operate. Don't worry about all of this except to say that if you are one of these 26 contracts from the Medicare and Medicaid Center for Innovation, you're working on 11 different indicators, 10 of which have to do with clinical quality, 1 of which has to do with readmissions. And you're given a composite score based on how well you're doing on these measures and against how many of them you are reporting data. Now, Washington State has a contract through the Washington State Hospital Association. 31 states, including Oregon, are in one sponsored by us. We happen to have the largest 1,500 hospitals, 31 states. But you can see that in a place where you want to be moving up and to the right, we're making a lot of good progress. Not to leave Oregon out of the equation, I had them, frankly, at the last minute, so this is not the easiest slide to look at. But to give me the Oregon results against those 11 indicators. How much reporting is going on and how much change from the baseline data. And are they meeting the benchmark and so on. We are doing great work. Let me show you, again, back to just AHA and its Health Research and Education Trust. Back to those 31 states and 1,500 hospitals. We have estimated that we will avoid 122,000 instances of hospital-associated harm. We will have avoided spending almost $1 billion of care that wasn't necessary. Medicare estimates for all 26 that those numbers are 560,000 harms avoided, $4.1 billion in spending avoided, and 15,000 hospital-associated deaths avoided. That's phenomenal work. That's terrific work. Now, some would say, and they say it in D.C. often, well, you really shouldn't have been doing all these bad things to start with. Fine, whatever. We're on it. We're getting better all the time. Some of them cost an awful lot of money. This one here is EED, early elective deliveries. Volunteer deliveries before 39 weeks. And frankly, when you eliminate those from your patient experience, you have a significant impact on your NICU. Good news for the kid. Good news for the family. Probably going to be continuing good news as that child develops through early years. Bad day for the CFO. One of your best paying services, gone. Not gone. They're still necessary. But a whole lot less utilization in an NICU. Right thing to do? Absolutely. There will be more of these. We will learn a lot more about what not to do, and we will immediately eliminate it from our roster of services or our revenue stream because it's the right thing to do. Another area where we're getting better, publishing our costs and our prices. So, just to make things interesting, call your hospital and ask them for the price of, let's say, a scan or a knee replacement. you really want to ask for the same code, because I'm also going to ask you to call a local independent center, a surgery center, an imaging center, whatever code you pick that's applicable, and find out who can give you who can give you a price. We gave our board and our regional policy boards this assignment, actually twice, once 6 years ago and once this year, and said, call your hospital and ask for the price. Most of our CEOs and senior execs around the table said, it's pretty embarrassing. Now, some came back and said, boy, we've been working on this. So I'm not going to say everybody doesn't have it right, but call your own hospital, mask your voice, have your brother-in-law call, whatever. And I think you'll be surprised, and I hope you're pleasantly surprised, but my data would say no. So short of being able to tell people a price, we at least put together this consumer guide with the hospital CFOs, the Healthcare Financial Management Association, to explain to them what bills they're going to get and what some of these terms mean. In-network, out-of-network, copay, deductible, co-insurance, what is all this stuff? To demystify this. And as I told the senior execs today at Kadlec, if nothing else, when your brother-in-law starts teeing off on you over drinks at the holidays, give him the book and tell him, here, you figure out your own bill. Don't come to me. So we're getting better at that, but this is a big deal because the world's going retail. A high deductible health plan for somebody with a $5,000 or a $10,000 deductible, they care now what a scan costs, and they will shop. And furthermore, the days of saying, well, that scan wasn't done here, I think it's of questionable quality. Unless you can prove it, some consumer protection group's going to be on you to say, you're just charging them a second time. So the world is becoming very transparent, very much retail. Now, a third place where we're doing better but still have room for improvement is in a very important area of diversity and disparities. We are part of a national call to action along with the Catholic Health Association, the Association of American Medical Colleges, the public hospitals, and the American College of Healthcare Execs, to say we need to do three things better than we've ever done before. And it used to be because it was only the right thing to do. Now I'll make the business case. So looking at the first of those three things is on diversity. Are our boards and our senior executive teams reflective in their diversity of the diversity of our community? Across most of the country, our national data would show no. No. And we know that we're becoming a majority-minority nation. So not just, again, because it's the right thing to involve people from all sectors of the community, but we need to know how to better connect with our community and what the needs of those populations are. We've always said, but everybody gets the same care. And frankly, the data would show that that's not true. Everybody does not get the same care. And furthermore, when everybody gets the same care, different racial and ethnic groups don't respond the same way to the same care. And clinicians are figuring this out. Lastly, I said I'd make the case for it, and that's in the disparities area. We said we want to see us be able to collect data on our community, race, ethnic, and language preference data at admission. Again, not just so we know our patient population better, but in a pay-for-performance world where we might get our problems down to a certain level, we can't break through that if we don't know how to slice and dice the data on a demographic basis to find out where the pockets of underachievement might be. And so we need to use this data. 80% of people collect it, they say. 20% say they use it in their quality improvement efforts. That's a huge delta. That's a huge opportunity to eliminate disparities. So it, again, better for patients and frankly now better for us in a pay-for-performance world. Okay, now I led with three good things. Getting better, but still opportunities. Here's the bad news. So I'll give it to you all at once, all on one slide. Don't want to trickle this out. Pull the Band-Aid off, deal with the pain, and move on. I mentioned that in the ACA, maybe I didn't. I should have said. The ACA we agreed to forego about $155 billion in future payments from Medicare, essentially, to help pay for that coverage of 32 million Americans. We gave up some portion of our annual market basket increases. We gave up some disproportionate share funds that go to help pay for services used by the uninsured, because now fewer people in theory should be uninsured. Well, all of that was used to pay for coverage. Now they've cut us an additional $117 billion since then through a variety of mechanisms. All of this, if you want to just be broad in categorizing, this is all narrowing the annual deficit, trying to deal with the national debt problem and so on. This is budget driven. And it's driven by a lot of deadlines that have come in the past, so-called fiscal cliffs, that I'll talk about in a second. But we've got some particular problems here because they've become very creative in identifying these cuts. These coding offsets, for example, in layman's language, we went to a more specific form of coding what services are provided and consumed. And they said, well, your natural inclination will be to upcode. So this gives you more ways to outfox us and get more money from us. So we'll take it away from you in advance. When it first came out, they called it behavioral offsets, which we found particularly insulting. So we've been fighting that. They didn't like the fact that under the DRG program, you got some lengths of stay down to 1 day. So they didn't want to pay you the full DRG. So they start monkeying around with short stay policies and came up with something called 2 midnight, which I won't bore you with at the moment. Medicare used to help us cover the portion of the beneficiary bill that beneficiaries weren't paying. They've stopped paying for some of that bad debt. But the real interesting one, which my staff sometimes calls the new crack cocaine for legislators, is that sequestration was put in. Now, this was an across-the-board cut, and for Medicare it was 2%. And it was for 10 years. And then the calendar flipped the next October 1st, and there was a new 10th year. So they extended it into that 10th year. So now you've got 11 full years of cuts, right? And they took the savings from the 10th year to pay for things this year. Did you follow that? Okay, so what happened recently that's really depressing? Happened just last week. A new year, October 1st. New fiscal year. So now there's a new 10th year. You want to lay bets tonight on where they go in the lame duck Congress when they start looking for savings? So in effect, what they're doing is setting a whole new baseline. 1 year by 1 year by 1 year, because eventually that 10th year becomes your first year. And you're looking at a whole 10 years of cuts that they've put in. Worse than that, all of these things went to pay for other health care issues, except last year they used health care funds to pay for a non-health care issue. This one got a little sticky in the advocacy world because it went to, in sequestration, they had impacted the inflationary factor on veterans' pensions. Went home and said, but I'll fix that. Came back and reversed it. And took health care dollars to pay for a non-health care issue, veterans' pension. Now, how do you come out against veterans? You don't. But you come out against the precedent. They tried to do it to extend unemployment benefits, and we beat them back on that. But now they start using health care dollars to pay for non-health care things. You know, bar the doors. Who knows where this is going to wind up? So that's the depressing part. We'll move on. I told you I'd prove you wrong. A lot of you say Washington never does anything. They do a lot of things. They closed the place down a year ago. They had a meltdown of their computer system. They've extended the debt limit. They've done some temporary patches for physician payments. They've extended some Medicare payments, which we thought were important, et cetera, et cetera. All of these items, starting with changes to the sequester in that out year, that 10th year, and up, are done because they're facing a deadline. Government's going to shut down. We don't have funding. We can't pay our interest on the debt. All deadline related. Or crisis. The VA. They had a political and, they thought, healthcare crisis on their hands, and in 6 weeks passed the bill and got the president to sign it, like the good old days when they actually legislated. Very different. Hasn't happened in years. So, let's look at some deadlines. First one, as I mentioned, was October the 1st because they should have done all of these appropriations across a dozen or 13 areas that would in effect allocate the money in the budget out to all the agencies for fiscal 15 starting October 1st of 14, the new fiscal year. They don't do that anymore. They pass continuing resolutions of shorter or longer duration depending upon the political impact. So that's just funding you at last year's level going forward for this year. So about mid-September or so, early September, I can't frankly remember the date the two chambers acted, they pushed the federal funding for agencies out to December 10th, past the November 4 election. I know you're shocked. I know you're shocked. So that they can come back in a lame duck session and try to deal with that problem. Now, they no way ever talked about a government shutdown. This is an election year. You only do those things in non-election years. You know, they don't think the public will remember 12 months later. But they're not going to do this. They pushed it forward. But they do have to come back in the lame duck and deal with it one way or another. Now, we're not sure when the lame duck will start. To get into politics, or at least elections a little bit, Louisiana, if neither candidate gets a 50% majority, they have a runoff on December the 6th. So you won't know, potentially, the control of the U.S. Senate, which is predicted to be somewhere around 50-50 by the pollsters. You won't know that until at least December the 6th. Or, frankly, since we put this slide together, we realize that in Georgia, the runoff, if nobody gets 50%, is January the 10th. 10 days or so before the seating of the next Congress on January 20. In Kansas, you have an incumbent Republican running against a Democrat and an independent. The independent used to be both a Republican and a Democrat before becoming an independent, and the Democrat tried to leave the ticket, tried to get his name off the ballot so as to throw his support behind the independent, because he was trailing. So we don't know whether or not the independent is going to get seated, and if he wins the election, who he's going to caucus with. Not because he used to be a Republican before he was a Democrat, before he was an independent. Because as an independent, you're allowed to walk in the day of and say, "Hi, I'm in your caucus." And either party will gladly accept you. And you've got an independent running in Maine. So you've got 2 seats, potentially, where you don't know which caucus they'll sit with, and 2 seats where you could have a runoff that take you into the early part of next year. The latter one takes you into next year. So we don't know what's going to happen in that lame duck. I won't even go into what some of the prognostications would be, because frankly we don't know. So the next fiscal cliff after October the 1st is December 31st, because in the Affordable Care Act there was a provision that took Medicaid payments to physicians up to Medicare levels, but only for 2 years. And the end of the second year is the last day of this year. So now we've got a debate about whether or not to extend that again. If we extend it, who will pay for it? And we've got a lot of physician groups who'd love to become designated as primary care in order to get the extra 2% bump. So there's even some inflation going on in that estimate as to what it will cost. But on a round number basis, it's somewhere between $5 and $6 billion a year to extend that. So it's not small money. We've got another probably granddaddy of all fiscal cliffs coming up April the 1st. Because last year when they fixed temporarily the physician payment formula under Medicare, they did it out to the beginning of the next Congress. Also, it's about the time that the debt ceiling capacity runs out. and they have to pass another bill to extend the debt ceiling so that we can pay the interest on the debt. So you've got two. This is about to fix this issue permanently on physician payment is about $150 billion over 10 years. Big money. Big money. It's been helped by the slowdown in Medicare spending. It's become less expensive. It used to be about $250, frankly. But because the rate of increase has gone down so much, the projections of what Medicare is spending over time are a lot lower. People in D.C. say, well, this is on sale now. You know, it'll never be lower. We ought to fix it. $150 billion is still real money. We don't know where to find that. And who knows what's going to happen on the debt ceiling question. So we've got definite fights ahead of us. We've got an agenda that says let's rationalize and make more responsible the way in which hospitals are regulated. We can go into some of those issues if you'd like. We've got to protect our most vulnerable populations in all of this so that we're still able to take care of them. That gets you into some of these special payments or delays in the ACA cuts and so on. Frankly, it gets you into what do you do about Medicaid payment, because about half the physicians in the country today aren't taking new Medicaid patients. I use that number broadly. I'm not exactly sure what the number is. I did see a number from an insurer the other day that said 50% of their family practice docs aren't taking any new patients. So we've got capacity challenges. We've got rural issues that have to be extended every year. They've never been made permanent, so we've got to fight for that. And then back to those cuts issues, back to budget predictability. So that's our priority list. For those interested in more detail, there's a legislative scorecard, a dashboard, I should say, on our website. These are things that they've been coming up with in a variety of ways that have been on lists over the last 3 years or so. The rule in D.C. is you never want to be on a list because you can't get off it once you're on it. So, whether it's more coding offsets or paying inpatient surgery the same as they pay outpatient surgery or surgery center rates, for example, changing some of the codes and so on. Bad debt reductions, I mentioned that as one area that they've already taken some money out. They talk about taking more. Graduate medical education, cuts to critical access hospitals, very important in a region like this. Post-acute care cuts. IPAB was the board that was going to kick in if the spending rate went over a certain level. Everybody but the president hates this. It's always a target for Republicans. We don't like it either, but it's never been populated or activated, so that may not be an issue. Medicaid, the way in which they provide federal support to the states, and then a drug discount program that pharma thinks has expanded too far that they'd like to see curtailed. So we're constantly fighting those issues on the budget predictability. These are areas of potential future cuts, along with that new out year, that new 10th year. So ways in which you can help as individuals. The AHA PAC, I always have to do a brief ad for that. We are bipartisan. Any contribution of any amount is most welcome. Helps us message to candidates when they're campaigning. It gets your phone calls returned. It doesn't buy a vote. We don't give them. You can't give them donations of that type of that size or magnitude. But it does say thank you to those legislators who've been helpful to hospital issues. So that's a way for individuals to be involved. Organizations can donate to something called the Coalition to Protect America's Healthcare. This is a donation program that buys advertising when we get into these budget battles to say to legislators, particularly those in key districts where they've got tight races, don't cut payments anymore. And so that's been a very effective strategy. This is corporate. This is individual. We thank you for anything you've done in either one of these. It really does help in D.C. So this also is on our website. This is our updated health reform platform. So this is my transition to where we're going. And just a couple of comments, and then we'll be done and take your questions. This is Ensuring a Healthier Tomorrow. It's organized under two overall themes of the changes we think still need to happen. Behind these 12 items, 2 themes and 6 items each, There are about 152 different steps that we think members of the private sector, public sector, payer, purchaser, provider, consumer, we all need to take in order to fix this overall system. The first area is promoting and rewarding accountability. This gets to the notion of performance, both results as well as transparency. So things that can be done, obviously we've got to figure out what that new payment system is, and the payment system will drive the delivery system change. It's not a chicken or egg question. We've got, if we want to see the health system organized differently and focus on different things, you have to follow the money. You have to change the financial incentives. So, you know, in a world where you can either go a la carte and, you know, focus on payment per whatever and, you know, a volume orientation, or you can say we're going to pay you based on performance, or we'll give you some fixed amount of money, a capitated rate or a global budget or something like that. And we think, frankly, it's headed that way. We just don't know when. And we're not entirely sure that Medicare has the systems to support that, or that, frankly, we have the systems internally to manage it. But it's coming slowly but surely. Some of my members have 2/3 of their payment under a capitated rate already because they own a health plan. So they're pushing to get 100% paid that way. Others are saying, you know, there's no way I could do that tomorrow or in the foreseeable future. So that'll be a challenge for us. Eliminate preventable infections, complications, right? That's back to that HEN contract that I mentioned, the Hospital Engagement Network, those improvements. More direct responsibility, engagement, support for individuals to manage more of their own health. You know, we've got to get away from the consuming mentality of healthcare to one where there's more participation by the individual. They see themselves on the healthcare team. We see them on the healthcare team, where the medical home is the home. It's not some apparatus we create between the hospital and the home. It starts in the home. Or as a friend of mine in a very poor urban area says, food is the first medicine. You know, why don't we start with more support for a health orientation? Better manage advanced illness, end-of-life care, palliative care, the kinds of things we haven't been willing to talk about ever since some smart person did a very destructive thing and referred to death panels as though we were somehow or another going to either let people die or push them in that direction. So now we're coming back around. We're starting to talk about it. People are starting to say, you know, this is something that we need to address. We'll see how far we can get this time. Keep going on electronic health records and more on transparency in both the quality and the pricing side. The second area, use limited healthcare resources wisely. Eliminate non-value added treatments. We have to stop doing things that don't benefit patients, that only further expose them to the potential for harm, but have no clinical value. The physician community, led by the internist group, has come up with the Choosing Wisely campaign, and other specialties are adding to that. In our case, you'll see on the next slide a document that's also on our website where we've identified 5 areas to start with where we think hospitals can stop doing what's not providing benefit. And they're in the areas of blood product management, antimicrobial stewardship, not easy for a non-clinician, end of life, ambulatory sensitive conditions, which means don't admit when it can be done outpatient, and stents. We've produced toolkits on our website, ready for download. All of these are free, except nothing's free, you know that. So you've prepaid them through your dues. But you don't have to pay to download them. The first 2 on blood and antibiotics are now available, all done in conjunction with the other national professional groups and specialty groups and so on. End of life is coming, I'm told, our 3rd one, and then the other 2 to follow. Revamp care for vulnerable populations, particularly the Medicare and Medicaid dual eligibles, people who typically are 65 or disabled and on Medicare, who are also poor enough to be on Medicaid. And the 2 programs just don't match up to support a very high utilizing, expensive, chronically ill population, where an awful lot of the dollars are utilized. So we've got to work on that. We've got to promote population health, pardon me, a very popular term these days, but one that we really haven't defined, and we don't know the role of the medical system. We don't know the relationship to the public health system. We don't even know what population we're talking about. Is it a capitated population? Is it a geographic population? Who are we talking about? Who's going to play what role? How do we get it done? But the point is, we've got to deal with it rather than wait for people to be so acutely ill that they crash at the ER or the front door or whatever. Modernize federal programs. I don't think we need to talk about that too much. Admin simplification and regulatory issues, and reform the medical liability system, which is the most popular question I get. When are we going to get medical liability reform? And it's been passed 9 times in the House. It's never passed the Senate, even when Republicans had 55 votes in the Senate. So it's not going to work. This president took immigrants and medical liability reform off the table before the debate on the ACA started. So that wasn't going to happen. And I told the group this afternoon, the last time we had medical liability reform in this country, it was in the state of Texas, where they had Republican House, Republican Senate, Republican governor, and 9 elected Republican Supreme Court justices in an otherwise totally bipartisan effort. So to finish up, we know that everybody is trying to reinvent themselves as hospitals, trying to know where to go, figure out where to go next. What role are we going to play in this? This is a cover of a book that I mentioned. It's also on our website, and it's also free to download. That talks about the fact that we've got to get from this current model to the next model, some sort of volume to value type of approach. And there are going to be lots of different paths that organizations might take. This would be an easier way maybe to look at some of those options. Number one, the world's going to become more integrated. We know that. More integrated, more at risk financially, and more accountable. So just looking at the at risk and accountable, you have to be good. You have to be a well-functioning organization to either succeed with a fixed payment, let's say, or to be attractive to somebody else if you're going to integrate. So what results do you get? What's your financial performance? You know, how strong are you? If not, then you have to become strong. You have to figure out a better way. So for some, they will, well, everybody in one extent or another are going to redefine themselves. In some cases, some will experiment and try to do different things, maybe different relationships, different orientations, different service lines. Some will actually just explicitly specialize and say, we can do X really well. Send us all of your X, and we'll be your X partner. Some will integrate, hospital to hospital, hospital to physician, delivery system to payment system, acute to post-acute, but build out more of a connected, coordinated system. Some won't have those parts and won't be able to provide those parts. So in one way or another, we're probably all going to wind up partnering. When we did a survey, that was the one that came out the most. Everybody said in some degree or another, we're going to redefine who we are, we're going to integrate more heavily, and we're going to partner. In some cases, they said we'll figure it out as we go. In other cases, they said we just know we got to slim down focus. So we've been asking the questions, about 24 questions of our members, where they think they're going. And we call it redefining the H. We don't want to change the name of hospital because we think hospital is a very strong brand. Everybody on the highway knows what that H means. So changing the name isn't going to help. But redefining what it means to be a hospital and what people can expect on the other end of that street when they see that sign is where we're headed. So we've been asking people, how are you redefining the H? We've asked now about 1,200 people coming to our regularly scheduled meetings to answer as homework about 24 questions. And here are the highlights of the answers. And I'll end with this. Nationally, they predict that more hospitals will be in systems, multi-hospital systems. Today, 60% of AHA members are in systems of 2 hospitals or more. Some go as high as almost 200 hospitals. They predict that 60% will go to about 75 to 80%. More physician affiliation with hospitals. Today, our best estimate is about 45% of physicians are either employed by or under direct contract to hospitals. People are saying that that's going to go to 75 to 80%. More providers owning health plans. Today we have about 15 to 20% of our members, by our best estimate, with health plans or investments in health plans. People expect that to go to 30 to 40%. More value-based payments, more fixed and capitated payments. The numbers, again, on average across the whole country are in the 10% range, plus or minus. It's not a lot yet, but growing. In some areas, like I said earlier, some are well over the 50% mark. But everybody believes that that's going to at least double, if not grow more in the next 5 years. Then we ask them, well, what about your own market and your own organization? What do you see coming? Decreasing total revenue. People expect to see less money. And I think that the real question for us will it be a slower rate of growth in our budgets, in our revenue line, or will it be an actual decrease in revenue? And I think everybody's trying to sort that out, but for most people they're saying, I got a plan for the absolute decrease. Anything else will be gravy. Oddly enough, if the revenue is going down, we didn't get a strong indication that people thought that costs would be increasing or decreasing. I think you can figure out faster than I can the problem with that view. If revenue is going down, costs had better go down. You heard it here first, okay? Write that down. More of a shift to outpatient. We're already paid on average more on a higher percentage of our revenue comes from outpatient than inpatient. More primary care, urgent, community-based services, and so on. So now we go from less intensive inpatient to inpatient and outpatient, and now out into the community. Again, a redefinition, a reimagination of the organization and configuration of our delivery system. Same or fewer inpatient beds, being a lot of capacity and beds being repurposed to other things. More patients will have primarily, most patients will have primarily electronic healthcare interactions. Maybe not people in my age cohort. Maybe I'll get out of this world alive without Facebook or Twitter or these other things that I don't want to know anything about. But kids will be, this is how they want to interact with everybody, including their physician, their pharmacy, whatever else. So more remote monitoring, more telehealth, more electronics. More retail clinic visits, but not by us. People are expecting Walgreens, Walmarts, CVS, Rite Aid, you name it, to be in that space. They say, most of them, that they want to be a partner. They don't want to take over as the medical home or primary deliverer of care. We'll wait to see how much of healthcare they like or don't like. We'll figure that out. Less use of medical resources, I mentioned that. Implementing multidisciplinary teams. We're just not going to have the physician population and probably not the nurse population that we think we need, so we've got to reorganize the way in which we deliver care and in a more of a team-based setting. Conducting telephonic outreach to discharge patients. We have one hospital that I thought was very intriguing. They said to us, we have banned the word discharge. You are never discharged from our system. You might be moved over to the healthy section or the self-care section, but you're still going to hear from us. We're still going to relate with you, interact with you. You are not discharged. You are repositioned, replanted, whatever, in some portion of our system, because we'll be health to wherever. half are implementing predictive analytics to identify high-risk patients in some areas. And we said, well, how are you doing that? And they said, well, we got a real talent gap here. These are some of the things we need. Predictive analytics, population management, variety of things. So what we know we need to know and learn about, we're admitting that we're just starting to learn about it, and including the types of people that we need going forward. And like I said, partner or experiment, but that's going to vary by different types of hospitals. So let me end there. The last few slides just simply had to do with all of those reports that I mentioned. They were free and on our website. Okay, fine. We'll just skip that for now and say thank you and see what questions, comments, messages you might have for me. Thank you.
Thank you, Rich. And if you have any questions, we just have, raise your hand. I'll bring the mic so we can all hear. And for the benefit of Nick, who's recording this,
you're not allowed to leave till 9 o'clock. Is that right? Aren't they locked in here until 9?
Rand, is that your call, 9 o'clock? Anyhow, if you have a question.
Questions, comments, debates?
I would have a question from my realm in communications, and you touched on the price transparency. What is your, I guess, top advice on when we get that question of, you know, how to make sense of the price of healthcare when we're, as you alluded to, shopping it now?
Well, my first answer is not the charge master. Charge masters are so out of whack and out of balance that, frankly, for those who are negative, they're like the gift that keeps on giving. You know, there'll be another, you all saw the Time magazine article, the Stephen Brill Bitter Pill article of, what now, a year and a half ago, something like that? A year ago, last February, I think. We're almost due for another one. You know, somebody discovers again that an uninsured patient got an outrageous set of charges from a hospital. And here goes the whole argument all over again. And we sit there and say, yeah, but those charges don't mean anything. They're only used internally. Nobody ever pays that amount. We got a great financial assistance program. At which point, you know, we've lost them. The soundbite is over. So we've got a problem. We don't know how to solve it. How do you get off of the charge master when some hospitals are still being paid a percent of charges? How do you get off of a charge master when, if you're being paid a percent of charges from different amounts of charges from different payers, how do you do that and do it in a way that doesn't give them an opportunity to cut your rates? And Medicare will only deal with you on the charge master one hospital at a time. So we don't know what to do about it. That's a problem. If nothing else, work with your payers and insist that the payers, that it's a problem for them too, and they know it's a problem for them too. So that together you can build some sort of calculator, so estimator, so that you can give people a reasonable estimate and have some payer data that you don't otherwise have on which to build that, and then have, ideally, some real-time connection to the payer to say, well, I'm not quite sure what your copay and deductible is, but, oh yeah, it says you're on the blue ABC program, and under that program, here's your obligation. Other than that, it's a simple problem. Yeah.
Being married to a public health physician for many years, I hear this a lot, and I'm not sure how it works in with your financial portion, but where does preventive medicine fit into your long-range goals and needs?
Well, let me go back to my experience. When I was in Spokane, I was on the board of and chair of Group Health Northwest. So we had Group Health in Spokane and the Tri-Cities, North Idaho. And I learned from the then president that something that was kind of like blindingly obvious, but he was the only person really working hard on this, certainly in Spokane County. He said, my best friend and partner for my capitated population is the public health officer. And I'm thinking, well, what portion of the capitated payment goes to the county health department? You know, like none. He said, no, I got 200,000 people in Spokane, whatever the number was. He said, they're out there every day mixing it up with all those sick people. I want to see an effective public health function so that the incidence across the community is lower, so that my share of that community doesn't come in here sicker than they need to be. I think it's waiting to happen. The problem is that we grew up with separate regulations, separate payment systems, separate professional advancement tracks. Basically said, that's your stuff, this is our stuff. And that's why I say we're fumbling around today to try to figure out what the right mix is. I think public health has been underfunded. Some would argue that maybe because the medical system has been overfunded, you know, that money had to go somewhere. But they're appropriated differently and separately at the federal and state level, so that's a little bit of a six-pack question. You can't answer it without a six-pack. But you know, I think it's finally starting to happen. I just don't know exactly how it's going to come together, but it has to. It has to. Good Lord! I mean, look at the SARS experience. Look at the Ebola thing. You know, I mean, right. All of a sudden this becomes everybody's problem real fast. Yes, please. Oh, I'm sorry. You've got the microphone. Dennis.
The OIG has not particularly been a friend of critical access hospitals and hospitals in rural areas in the past. And this question may be too early for you to answer, but you know, they looked very unfavorably on our cost-based reimbursement last go around. And I've heard that there's a new report, still embargoed, but rumors are leaking out of it regarding OIG in terms of how they're looking at critical access hospitals and payments of deductibles and copays. Is that something that you're familiar with at this point, or is it just too early to really understand what might be coming out there?
I am not aware. I had not heard that rumor, so I can't tell you whether it's, you know, there's anything behind it or not. I don't know.
Okay.
Is it safe to say that once an agency gets on a track, they stay on that track? You know, like I said, once you're on a list, you can't get off the list. That's entirely possible. Did the OIG, the Office of Inspector General, hit on some points that are difficult for us to fend off? Yeah. You know, when it's critical access and they're 10 miles apart, you know, again, a lot of that goes back to the latitude given to governors before a certain deadline back in '06 and so on. But they're saying that a program that was targeted for about 400 hospitals is now 1,400. What's going on here? And is this still the same way to go? I think that the safest or the greatest protection for rural, period, healthcare, education, whatever, is the U.S. Senate. Whether you're California or North Dakota, you get 2 votes. And that's where the rural strength in this country comes, political strength, comes from. All those, people in D.C. describe it, all those big square states, you know, kind of in that western part of the country, they all get 2 votes. So all the populations on the coast, all the votes are evenly distributed. So I think it's going to be very difficult for a political case to succeed in fundamentally changing rural health care. On the other hand, I think the economic case is blindingly obvious. The question becomes, what are we willing to support when they're on a very small population and very small tax or financial base? So, you know, I come from a town, I'll talk about Spokane. Back in the 90s, many of us were arguing for government consolidation. So we fixed that problem because we had a city and a county and lots of overlapping things. We fixed that by having a third government. A new incorporated area with a government that used to be part of the county, you know. What are we willing to pay for? Which gets me to a different area that maybe somebody was going to ask about, but the studies are very clear as to the problem we have with Medicare. We all have paid in, or will have paid in, about 1/3 of what we will take out. So we're back to the old question of what services do we want to pay for, and how do we want to pay for it? How much are we willing to pay for? And so I had a friend of mine, a colleague, say to me, I've announced my retirement on December 31st. I'm leaving, and I'll be on Medicare. So I want you guys to keep it stable, strong.
Yeah.
And I said, that's really great, pal, because this was August. I said, you've got between now and December 1st to write that check for the other 2/3. I mean, it's just about that blunt. I think you had a question. Yeah.
So I'd like to ask a question about innovation and delivery models. So on one hand, we have some demonstration projects which have been in the news over the last week, where CMS demonstration projects, there are a bunch of healthcare delivery plans that are bailing out of those demonstration projects. And you haven't talked very much about what's going on with employer-driven innovation. And I work in Seattle at Swedish, and we actually think that the sort of Boeing work that we're doing there is more innovative and driving more interesting conversations around delivery of healthcare than perhaps we'd seen in other places. So could you comment a little bit about the difference between those two?
Yeah, sure. Well, first of all, to the current Medicare demonstrations, I'll use the ACO label, particularly some of the more at risk, what they call the pioneer ACOs as opposed to the shared savings ACO. We have seen people drop out of that in first year and second year. Generally speaking, it's organizations that are already in low-cost, low-utilizing areas who said there just isn't enough potential, enough upside, enough juice for the squeeze, for the effort. One of them, one of my board members, has an HMO that's in the Medicare Advantage plan. And they said, this ACO doesn't offer me anything that I don't have in the Medicare Advantage realm, and I get a lot less burden and regulation. And I have a better, I'd rather put my time and effort there because I think it's a better program and a better return for my effort. So in general, I have to go back to the beginning that says those things were set up in the ACA as demonstrations because we didn't know if they'd work or not, and we're learning, and you learn by what doesn't work too. Now on the private side, we have every reason to believe there's a lot more experimentation going on because we have innumerable numbers of payers, and they're free of all of the federal regs and so on, provided they stay within state insurance laws and so on, to experiment with willing provider partners. We just don't have a good way of gathering, collecting, and analyzing all of those different experiments that are going on unless the payer and the partner publish it. So it's a little harder to track, but there's no question in my mind that there's a lot more. If you just go, kind of ACO for ACO, there's a lot more on the private side than the public side. And yes, we are seeing health plans. We're seeing employers go out for bid, if not actually, move inside of health systems in some cases, almost virtually, or totally outsource and totally partner back between the health system and the provider. You're seeing some shared savings types of approaches and some total channeling of volume to narrow network or selected partners and so on. You're seeing all of that go on. It is, everything you can imagine, I would say, it's safe to say, is being tried somewhere by somebody. And the question is, what's going to stick? The last thing is the state. And I would suggest you keep your eye on two states. Because at the moment, two does not a trend make. But in Massachusetts and Maryland, they have basically said, we're going to cap the amount of money spent on healthcare in this state. We're going to tie the increase directly to the state domestic product. And you're going to get a global budget and no more. And this is how much it's going to go up each year, according to the state domestic product. One thing that fascinates me is that there are 10 hospitals in the state of Maryland. They're rural but not critical access. They're good-sized rural centers that pretty much have their own geography. And for the last 3 years, they've been given a global budget by the state. And they are very positive about it. They're working their tail off. But they said, we get the money, we know how much we're going to get, We're responsible for whatever inpatient care is utilized by anybody who shows up. So community in this sense is open door. And they are rushing to get out into the community to better coordinate services earlier on the preventive side, working with public health, working with community colleges to bring up more community health workers. They're not waiting for more physicians to be produced. They're reinventing themselves, and they're excited about it. One CEO said to me, "I'll never go back. If you make me go back to the old system, I'm finding a new career." So I think there are things to look at. Again, we just have a hard time figuring out all of the different things going on in the private sector.
Yes, good evening. You write here that in 5 years, the overall forecast is that most patients will have primarily electronic healthcare interactions. Do you think that that is the regulatory preference, that regulations will increasingly move us in that direction, particularly when we look at requirements such as meaningful use? Do you think that is the regulatory preference to move as many interactions as possible to an electronic form? And if that's the case, how can hospitals best prepare for that and hopefully even profit from that in the value-based model?
That's a great question. That's the first time I've been asked that question, so it's a great question. It makes me think. Without sounding flip or demeaning to regulators, which I don't want to do, I think that would be in the category of really advanced planning. I mean, I think they're fighting battles that are much closer to home today to say that it is their preference. I think the answer that you got from that survey is coming from the market, where people say, as a consumer, I really don't want to spend 3 hours of an afternoon, trying to find a parking spot, going into a clinic where maybe the doctor's on time, maybe they're not, then going over to a separate pharmacy, and then if I need an X-ray, going to a third place. I want to do this on my terms, a lot more electronic. People are willing now to have what I'll call a traditional telehealth visit with a physician. Don't have to be in the same room. People are even willing to have group visits electronically with physicians. And then they become their own support group. And the physician becomes a kind of a sort of a leader consultant. It's just a different way of relating and communicating that people are expected to apply to healthcare. Now, the other thing is, your utility company now drives by and shoots some sort of device at your meter and tells you how much water or electricity you used last month. People will be sending in results from their bathrooms or their kitchens or wherever so that they can be monitored. That, too, is electronic. That's not far out at all. That's happening already. We, if paid a global budget or a capitated rate per person, don't want them coming in if we can deal with them on a remote basis. Much rather put, a talking scale or some X-ray gun that they can, beam it themselves and give us all the vitals, so we don't have to go out there. So I think it's just coming. I don't think I know of any agency that has it stated as a preference. Certainly the Office of the National Coordinator for Health Information Technology has a vision in that regard, but it has not been made concrete, explicit yet by the payer side of the equation. By the IT promoters, yes, not by Medicare or others.
Back to the ACA, so could you give a prediction on the outcome, the debate over state and federally run exchanges and the tax credits? And
oh, yeah. That's a great one. The Supreme Court. You mean you want me to play Chief Justice?
Yes, I do.
Well, we certainly believe that there's this thing, when you look at legislation, you can look at the words, and you must, and you can look at legislative intent. And there's always a legislative history, and either an expressed intent or a deciphered, interpreted intent, which is where the court comes in. And I can tell you from being there that this was never intended to exclude subsidies for individuals through federal exchanges as opposed to state. Everybody who was ever involved in it who wants to go by the videotape, you know, and not make things up, will tell you it's a poorly drafted provision. Will the Supreme Court see it that way? You know, that's where I think, you know, it's going to be another one of these 5-4 decisions. We have a hard time imagining how they cannot see it that way and not appear overtly political. But I never would have predicted the outcome on the tax and Medicaid expansion questions either. So, you know, we certainly hope and believe that they were intended to have tax subsidies available to all people who qualified for them, whether you were in a state-run exchange or a federal exchange. Think about the politics of it. Why did you wind up with 52 state-level exchanges? Because the feds said, and particularly the president and the Democratic Party said, you know, if we try to mandate this as one exchange across the country, this is national health insurance, this is going nowhere. But can we tell the state they have to form an exchange? No, especially if we don't fund it. So if you want to do it, states' rights, local government, you do it. If you don't do it, we're prepared to do it. And in there they got bad language. The rest is all politics. Did I not answer that question? I didn't place my bet, did I? No, yeah, right. Yeah. I've learned.
Any other questions before we adjourn? Yes, sir. You might be pull that away.
Yeah.
You might be close to that speaker.
What, if anything, do you think we can learn as hospitals from retailers like Walmart, given that the consumers are becoming more geared toward that type of experience? We've learned a lot from Toyota and Boeing. Is there any lessons we can learn from retail? Thank you.
I think the world has gone retail because people are more responsible for more of their own costs, and they're actually shopping on a regular basis. So therefore, who understands retail? We've never been built retail. We've been built wholesale. You know, we deal with large groups through contracts with insurers and so on. So by definition, somebody out there is more knowledgeable than we. And certainly those who are in the retail business dealing at the sidewalk with parking spaces, by the way. Something very short supply around hospitals typically. Convenience, you know. They've figured out the shopping hours and patterns. They know more about that consumer at the point of sale than anybody. So I think there's a lot we can learn. Walmart, to me, is the exception in that they have been able to build such scale that I'm not sure anybody else can do what they do the way they do it. You know, $4 for a generic prescription and so on. I mean, that may wind up being the most successful model or not, I don't know. But it's going to be very hard for anybody else to try to duplicate it the way they do it. But, you know, when you get down to the others, I take them at their word, that they'd rather partner with you, us, and work more closely to, you know, if CVS claims to be within, I forget what they say, something like they're within 5 miles of every consumer in the areas that they're in, you know, and they want to do that nationally. Boy, we are not within 5 miles of every consumer that utilizes us. So somewhere in there has to be the opportunity for a partnership, and I think it's through working together that we learn from them, and frankly, they learn from us because, you know, they see healthcare as a great big market, but maybe some haven't gone far enough into some of the realms of healthcare to know some of the intractable problems and vagaries of this system. Yeah, I think there's a big future there. They see a big opportunity. They think convenience is it.
Anybody else? Rich, thank you for spending your evening with us.
Thank you very much.
Traveling cross country. And
great to be here.
We obviously have some shared challenges in eastern Washington, and they're common with what you're dealing with in Washington. We appreciate what you're doing, and thanks again.
Thank you. Thank you. Good night.